Am I on? There we go. Yeah, so sorry, Mark there and Corey step in, which is like so much fun. I'm so glad because you get way more out of it when you have different perspectives and you can ask questions. I mean, because Corey and I have similar practices, but there's still stuff that is different. So I think there's huge value. So thank you for stepping in on Sunday morning and doing that. So here's all my financial disclosures, all have been mitigated. There is Mark's. We don't have Corey's, but he's got
You'll see it later.
You'll see it later. So when I talked earlier about when should we test for dry eye disease, and we are really intentional in our clinic about looking for making sure patients don't have dry eye disease. And one way that we do that is with the speed questionnaire. So what do you do some kind of questionnaire survey in your clinic?
It's actually funny. So we're looking at potentially integrating one again, but we've actually kind of gone through different phases where when I first started at practice with Dr. Epstein, we were using one, but then for a while we actually found that we were just doing verbal screeners.
Yeah.
Because that gave us about the same results because one of my best screeners was I go in and the first thing I ask the patient, even if it was like a primary exam, care exam, was, your eyes ever feel irritated, dry, scratchy, or bother you whatsoever? And that gave me all the information I needed right there. And it took me all of 5 seconds I had.
I love that. See, there's multiple ways to do this. And the point of that is no matter how you do it, whether it's on a sheet of paper that somebody's filling out that your staff is helping you with, whether you're asking pointed questions in the room, the bottom line is 40% of people in their 40s have dry eye disease. And when we look at when that starts, it actually starts in their mid to late teens, early 20s. I mean, when you're looking at meibomian glands, we have teenagers at this point that have lost half of their meibomian glands. And we don't see the repercussions of that typically for years to even up to a decade based on this information. But what would happen if we intervened earlier in all of these patients' journeys? Would we ever get a stage 4 patient that we're throwing the kitchen sink at if we could intervene earlier? And so that's all this.
Yeah. And what do you think this graph is going to look like in 10 years?
It's going to shift.
Exactly.
So all the way to the left.
So I've thought, so I don't really see pediatric patients, but in 10 years, that's probably going to change because I'm going to be seeing lots of pediatric dry eye.
Yep.
And I'm already starting to see it now. So we talk about this. I love this that we're talking about, everyone in their 40s, because that's the classic patient. Because if you look at like the old literature, what you see is who's the classic dry eye patient is a postmenopausal woman. That's what you always see. We are so beyond that right now. And some of these demographic shifts have been slow moving, but some of them are now very rapid. And the biggest difference is because we have now transitioned everything to, well, for adults, the big thing is our leisure time has now shifted onto our phones. Because it used to be like, if you look at, they're like, okay, well, why didn't we have this explosion of dry eye in the 90s? Because that's when people kind of started working on the computer. And that's because they went from their computer, and then when they got off the computer, like, oh, I'm gonna, go do something of this, even watch TV. Now what happens?
Yep.
Oh, I'm done on the computer.
Sweet.
Okay, let's go to my small screen. So we never stop our screen time. But what's happening then for kids is, for instance, well, kids play video games all the time. I play video games all the time. What's happened for them is the opposite. Their play used to be on screens, but now their work is on screens. Because all young kids now, they don't get a textbook. They're given
a Chromebook.
A Chromebook.
Yep.
So we're going to see this shift. So to your point, the early detection is going to become huge. And for those of you who, thank God, you're doing pediatric care, you're going to be probably our first line for catching this.
Yeah, absolutely. So when we look at first things first, and I like to take these graphs that this is from Deuce 2, came out in 2017. They're working on Deuce 3 as we speak. And sometimes when you look at these, it's like, whoa, there's a lot going on there, and I'm overwhelmed, and I'm just going to move right on, and this resource is, 400 pages long. But I love taking these and then making them something that I can use applicable in my clinic. And so while it looks complicated, it's really not. It's what we just talked about. It's start with a triage question, a couple of questions like Corey does, a questionnaire. You can do it that way. Look for those risk factors. Are they on, the patient, the question earlier was, someone taking antihistamines, anti-anything, antidepressants, antihistamines. All of those things are going to dry somebody out. If they wear contact lenses, if they're on, if they smoke, all of those risk factors we need to take into account. And then diagnostic testing, if we're looking at corneal staining, non-invasive tear breakup time, and then looking at osmolarity. And while how many people in here have osmolarity? Okay, so do you have osmolarity?
We have it.
Yeah. So I like it, but it's not a have to have. You can diagnose somebody with three things: your questionnaire or the questions that you ask, looking at the cornea with vital dye, that should be done on every single patient. And then the last thing is just push on their meibomian glands. You have those three things, that is all you need to be a take off with your dry eye. And if you don't love dry eye, great. There's a couple of like really good people here that love dry eye that you can just refer that patient. And I have the same thing. I have a lot of ODs who are like, oh, I don't want to mess with this. So they send me that and I send them right back for their comprehensive care. And ophthalmology, same way. So when we look at desiccating stress, and we talked about this earlier, when the ocular surface structures fail to protect itself from desiccating stress, what are all of those things in the gray outer circle? So systemic drugs, like we talked about, where you've had surgical patients that, man, they seem to take forever to heal. Their cornea looks terrible. All of those things because you're changing what's happening with the corneal nerves. And then you can wind up with a neurotrophic cornea. So those are the patients that you look at and they stain terribly and you ask how they feel. Yeah, it's good. Vision's a little blurry, but I feel fine. That's because the nerves are no longer doing what they're supposed to be doing, right? And then you have the opposite where the nerves are so irritated and so overstimulated and upregulated that you've got a neuropathic patient who you look at looks pretty normal and they are miserable. So we'll talk a little bit more about that later. But the point to this lovely graphic is there's multiple ways to enter into what's happening in that vicious cycle. And when you get tear film instability, now you get hyperosmolarity, and this is why I utilize it in the clinic, because hyperosmolarity is like my IOP for glaucoma. It tells me where we are. The body should have an osmolarity state of around 300. And when you look at hyperosmolarity and what it's actually doing and what it measures evaporation. So think about it. If you have 2 glasses of water on the table, you put the same amount of salt in both glasses and you fill one completely full and you fill the other one halfway full, which one's going to have a higher osmolarity? The one with less water, right? That's what you're measuring. You're just measuring that evaporation rate. But the point to that is why that's important and why that matters, because the corneal epithelial cells start to die in a hyperosmolar cornea. What does that look like? Surface staining. So that's why you don't necessarily have to have osmolarity. As long as you're looking at the corneal staining, you're going to see those end effects, right?
Yeah. And the way we do it, because it's something that at this point we don't necessarily even routinely do because it doesn't change what we do.
Yeah.
That was our big thing. It's like, unnecessary testing to me is unnecessary testing a lot of times. That being said, what we'll do it a lot is in studies because it's a good marker to have. And for me, the way I've always thought about this, because there's such physiological variance. Yeah, we do have normal ranges. Not all of us are going to be the exact same. So for me, a lot of times if I do osmolarity, it's a set point. I want to see where they're at relative to where they started. So yeah, because they might come in and they're normal in the range and they're miserable and you can see all that thing. So for me, it's like, okay, I'm not going to be looking at them. I'm like, no, don't worry. The osmolarity is fine. You're just fine. You can go home. No, so for me, this gives me a baseline that I can compare it to in the future.
Yeah. And then once you get into that, now we have inflammation. Now we have MMP9 activation. You can measure MMP9 if you want to. And then now we have goblet cell loss. And goblet cells are responsible for the mucin that everything sticks to. So, you have that patient that comes in, they're like, man, my eyes water all the time. Well, actually, what's happening is you have dry eye disease. They're like, whatever, you're crazy. My eyes are dry. No, they're not. They're watering all the time. But it's because they don't have the right mix of tears. So they don't stay on the front surface because you've lost goblet cells. So that's helps you explain all of that. And then, of course, meibomian gland dysfunction is part of that tear film instability. And now we lost homeostasis and we just stay in that circle and spin. So we talked about symptoms, multiple ways to do that. Point of care testing, we just talked about with osmolarity and MMP9. Do you have to have those? No, but they are nice to have. And I actually like them together. Why would I like them together? Because when I have a normal osmolarity and a flaming hot MMP9, is that ocular surface disease as far as categorized as dry eye disease? No. It's either going to be, I got to start looking for something else. It's not always dry eye. It can be conjunctival chalasis. It could be EBMD. It could be frictional issues because of evaporation and literally the sheer force of the blink is tearing up the whole front surface of the eye. So the two together give me a lot of information.
And I think that's a good point because honestly, at this point, dry eye is, I even tell the patients, they come to me out of the dry eye center, I'm like, dry eye is a nebulous term that even when I try to define for you, it's really more and more And I know we talked about this even a lot this weekend. It's ocular surface disease is really what we're dealing with.
Yeah.
Dry eye is the thing that we kind of use just as a very broad term. And do you know why we use it? Because patients understand it. And I actually really liked your point about the tears being off, because the first thing I do when I actually talk to a patient is I tell them that, you're here for dry eye, but for the vast majority of patients, your eyes actually aren't dry. You're producing enough tears. It's that the quality of the tears is off, not the quantity. So that really kind of has to change their mindset, because otherwise some of the treatments that we do don't make sense to them.
Right. I love that. So normal is going to be around 300. If you have an intra-eye difference but over than 8, that's going to tell you some information. And hyperosmolarity creates light scatter. So this is why patients will say, my vision's just blurry, and it may fluctuate through the day. Those are things because when you look at light scatter, it's equivalent, if you've got a hyperosmolarity of 326, it's equivalent to someone having a stage 2 cataract. Stage 2 cataracts, are your patients blurry? Yeah, right? So this is the same thing, and you can see it bounce all over the place. So I love one of those questions of, does your vision fluctuate throughout the day? Because patients are not going to roll into your clinic saying, hi, my vision's, blurry. It's better in the morning. It gets worse as the day goes. It seems like this is happening. No one says that, right? You have to ask the right kinds of questions to discern that information. So we've talked about the tear quality. What about tear quantity? And I absolutely love tear meniscus height.
Yeah.
Right?
And do you do it objectively, or do you have like a measure that you do, or do you do it just behind the slit lamp?
I do both.
Okay.
But on a first patient, like in my primary care clinic, it's just with the slit lamp. And you can identify, you don't need any fancy equipment. No. You can absolutely, when you look at tear meniscus height and you're looking at that little tear prism right at the base of their lid and how many tears are there, when you see enough normal, you know when it's abnormal. So when I have someone that has a really high tear prism, then I'm also looking for conjunctival chalasis. Maybe I've got punctal stenosis. Maybe the lid's tipped forward and it can no longer drain. Those are all going to go down a different path when you might, I used to misdiagnose those patients with dry eye because they had all the symptoms of dry eye. And then when I looked, I was like, oh, they've got comorbidities. And then when it's too low, now you know that you have an aqueous deficient problem and you can probe, do you have dry mouth? Do you have other autoimmune diseases? And autoimmune diseases typically fall in umbrella. If they have one, sometimes they have multiple, right?
Yeah. And that's, and for me in our clinic, we primarily do non-invasive like tear breakup time. And then I also do an objective tear meniscus height evaluation. And the thing I like about that though, too, is again, it's a range. People think that, oh, as long as I'm above that 0.2, I'm great. But again, I'll see someone come in and they're above a millimeter. I'm like, okay, something's going on here. Yeah. And the other thing is this also skews your data as well, because when you have that super high tear meniscus height, what happens? Your breakup time is normally better.
Right.
And I'd say it's kind of like, it's a false negative on that, that they're making it seem like, oh no, your tears are super stable. No, it's just the fact that you have the tears just sitting on there for this. So really, I always kind of like to think about it between a 0.2 and about a 0.45. Above that, I mean, you can still be normal above that, but I start to get more suspicious once you get to that 0.5 millimeter and above.
Yeah, and you can see that at the slit lamp.
Yeah, right? Exactly.
So we've talked about all the diagnostics. Questions on diagnostics, how to diagnose dry, what that's going to look like in your flow. Okay, so now we're going to jump into, and these are in alphabetical order, by the way, that way we go through all the things. So artificial tears, and I learned this from Mark. I no longer use this term. I use lubricating drop, and you've probably heard me say that multiple times. The reason I say that is because there's nothing artificial about the natural tear. There's 2,000 different components in it. You can't artificially recreate that. You can help support the front surface with lubricating drops, but you can't actually do anything that's going to make all of those components of a real tear. When I do use lubricating drops to help support the front surface, I look for a couple of things. I want them to be preservative free. I like trehalose things, and I like hyaluronic acid. So don't use it as your primary therapeutic approach, but you can absolutely use it to, I kind of almost use it like a rescue when we're doing things and I need support. And
there's definitely extremes on this I've encountered, and I like to say my approach to dry is very pragmatic, because I've had some doctors who were like, it's so easy to fall in one camp or the other, and they'll like over rely on artificial tears. And I call them a Band-Aid in a bottle. They make your eyes feel better for a little bit, but they're not really going to fix the underlying problem. That being said, when you need quick relief, I still always recommend one, because practically you're going to need that. Because I have other doctors who will almost stand on academic principle and be like, I will not use artificial tears because they're not fixing that. But really, The answer is they have a place, and it's exactly like you said. It's like when you need that quick relief, that's where an artificial tear is good.
Neurostimulation. So I put this like right behind it, because if I have a patient that is utilizing lubricating drops, and I love what you just said about, you know, when you need something fast, but it doesn't actually like last a long time. That's a really, whoever asked that question earlier about the PAs, that's a really good question when you ask your patients, are you using any kind of lubricating drop, artificial tear that's over the counter? And then your second question should be, do they help? Because the patient's always going to be like, you know, they feel good for a minute and then the problem seems to come right back. And that's a beautiful point for multiple reasons, insurance, and because you can say, you're right, it doesn't, because you have dry eye disease that we need to address, so chronic long-term issue that you and I are going to manage, and I have great ways to do that. So neurostimulation is one way to get a real tear, because remember the lacrimal functional unit that is part of the trigeminal nerve. When you stimulate the LFU, what does it do? Stimulates all parts of your tear film. So it's going to stimulate goblet cells, so they're going to degranulate, so you get the mucin and the sticky part of where your tears sit. You're going to stimulate the lacrimal gland and all the accessory glands, so you're going to get all of those beautiful components of the aqueous. And then it also stimulates meibomian glands. So when you target the LFU, whether it's through a topical formulation or whether it is, which is not available by the way, or through the nose in that anterior ethmoidal section of the trigeminal nerve, you're stimulating the LFU, and your body will make its own real tears. And when I talk to patients about what we're doing therapeutically, that's my end goal. I'm trying to get your front surface back to its normal state, and I need your body to make its own real tears, no matter what our therapy. That's my closer.
Yeah, and for this one, I know a lot of times some people look at this, they're like, that's great. What's the chair time going to be on explaining this to a patient? So my big thing is anything we talk about or discuss, you should be able to get it down to 60 seconds at max or less.
Or less.
So the way I always describe this, because again, you know, we know about the trigeminal sensory pathway, we know about all that, but the patient has no idea what you're talking about. So when then you're going through the nose and they're like, okay, how's this going to help with my tears? I just say it's super simple. I'm like, we have a nerve that's in the side of our face. Think of it like a sideways tree. There's a branch that goes to the eyes, and the trunk is right here. So what we do is we stimulate this branch, loops back around, goes to the brain, and that's connected back to the eye. So right there, I've just explained to them in what was that, maybe like 15 seconds, and they get it intrinsically. Yeah. So I know that is sometimes a big barrier for doctors. It's like, okay, how do I do this? Just little things like that can go a long way, and a patient will just intrinsically understand it.
Yeah. So her question is, do we have a demonstration, like how do you stimulate it? So yes, either I do it or my scribe does it, but I show the patient how to do it, which honestly, that conversation and that I've timed it, and I can do that in less than 30 seconds.
Yep, exactly. Yeah.
But I do have them because there's nuances to putting something in your nose to treat dry eye. So yes, I show the patient how to do it.
Yeah. And I also say, you know, the biggest thing for
Oh, yeah.
yeah.
So I always keep a bottle in the room, and whenever we do it, I just show them how to do it. So that nerve lives on basically in that little tiny crook of your nose right here. So take the bottle, and it's not this thing you want to shove all the way to your brain, right? It's not supposed to be in your sinus cavity. You only need those receptors to bind that live right here. So I have the patient put it barely inside their nose and tip it towards their ear so that it's aimed towards the ear. Spray on the right side, spray on, and then immediately hold your nose. Why would I do that? Because anytime you put anything inside your nose, what do you want to do?
Yeah.
And that is the worst thing that you can do because it stings and burns, and you don't need it all those places. So I have people hold their nose, and then I actually have people blow their nose, because once it binds to the receptor, you don't need any extra in there. So that is what's worked best for me, and I utilize Neurostim a lot.
And I do the same thing, and the way I describe it, because I want the patient to remember it, and I tell them, I'm like, don't stick it all the way up like you normally do, because if it gets in your sinus, you're going to pepper spray yourself. Yep. And they always kind of laugh, but they remember very much with this. I'm like, it's basically, I'm like, oh, don't worry, you will tear. You will tear, but not for the reasons you want.
And I use the pepper spray thing too. So let's talk about lid structure and function. And this is that third piece, right? We have to look at how the meibomian glands function. You don't need special imagery to do that. We're looking at structure when you're doing meibography. I love meibography for education, but that is the only reason I like it. It doesn't tell you what's happening in the moment. You can have glands left picture and you push on them and nothing happens, right? That's non-obvious meibomian gland dysfunction. And those are the patients that you really want to catch, because whatever you're going to do is going to help. It's when you get to the nubs that you're trying to, revitalize and keep alive, that things go sideways and it's much harder to manage. So
I agree. The biggest thing for me is I absolutely love meibography, because over time it's actually relatively static if things are managed well, because there's some literature that says that you can get a little bit of regeneration, but I'll tell you that's not the major goal. That's a big thing for a patient, because if you show them that, and I'm always very for with them, because I normally only repeat that maybe once a year after I do the first thing, because it tends not to change too much. Right. But I always let them know we're looking mainly for stability, because otherwise if you show them the same image and they're like, oh, it hasn't gotten any better, you want the stability there. And I kind of see it like, I think a lot of dry eye care is similar to like basically glaucoma management. Mm-hmm. That's basically your OCT. That is the structural component. The functional component is exactly what you said. Pressing on the gland, seeing what's coming out of them, because that's going to tell you more. So it's one piece of the puzzle, fantastic for patient education, but also informing your treatments, because I'm going to treat a patient differently that has nubs versus like full glands, because sometimes I'll see a patient does have dry, but man, their gland structure is fantastic. And that's going to change exactly how I'm treating it. So it's a lot of good information, but really not something you need to do at like every single visit.
Yeah. So let's talk about ocular rosacea. And when we look and identify patients, so, start outside the face and then we've worked our way in, right? We've looked at lids, we've pushed on glands, and now we're going to look for telangiectatic vessels. Because when you have telangiectatic vessels, there's your diagnosis of ocular rosacea, because there's different ways to manage that, right? And that's part of this comorbidity. And to somebody's point, I always have patients look down so we can look at the base of the lashes and identify collarettes, but you'll see all these telangiectatic vessels, and that was one of the clinical endpoints for lotilaner. 0.25% was actually, erythema, and we saw that reduction happened when you treat Demodex blepharitis. Lid evaluation, lots of ways to do this. You can, again, I use my digits because they are always attached to me, and there's lots of tools, but I still like these. And when I have patients, I do always ask this really simple question: do your eyes bother you more in the morning, or does it seem to get worse as the day goes? And when they say, you know what, man, I wake up dry, like I can barely peel my lids open, or I have to put drops in to even be able to open my eyes, that tells me that we have a lid seal problem, or we have lag ophthalmos, or we have both, because we're getting so dry at night. And this is one of Mark's patients that he's doing the core Blackie test on, looking at that poor lid seal. You can just use your transluminator. When you have all that light shining out underneath that bottom lid, that tells you that you have poor lid seal. And I'm going to manage that differently. We're going to talk about either moisture chamber goggles, ointments, things that are going to help at night. I've caused many a divorce trying to turn the ceiling fan on at night. Yeah. So we have to have other methods.
So I will say out here specifically, this is a major problem and it's underdiagnosed because we have such low humidity here. A poor lid seal here, that in basically a very humid environment, you might not notice. You're not getting away with that here. So I actually look at every single patient for this, and I do two things. The first thing I actually have them do is it's quick and easy. Tilt your chin up and gently close your eyes like you're going to sleep. I take the transilluminator and just look for a lid gap there. And then I just go over top, because if you see the gap, you don't have to do this test here to see the light underneath. And most of the time you'll do that. And basically what's happening is, I explained to them, even though that the lids are touching, what's happening is they're not touching tightly and making that airtight seal. So even though your lids are closing, they're not performing like that. And you're about to all see it too, because it is now ceiling fan season. And patients know. It happened to myself. I have dry eye. I turned on my fan as we hit in the 90s, and I woke up the next morning, I'm like, gosh, my eyes are dry. What's going on? And I'm like, oh, okay. What would you tell if you weren't a patient? Because I'm terrible at diagnosing myself. I'd be like, oh, the fan on last night.
That's what happened. And using vital dye is super important when we're looking at corneal staining. And I love using my little Ratten filter that you use to image and look at the fit of your scleral lens or your GP corneal lens, because it lights up like a Christmas tree. And I started doing this when I couldn't get lissamine because it was back ordered for the millionth time. And I was like, man, I need to be able to see conjunctival staining with looking at what's happening. And so I still use lissamine green when I'm looking for friction issues, but on a normal everyday patient, I'm doing fluorescein with a Ratten filter.
The Ratten filter is huge. It's like, you'd be amazed at the subtle things that you pick up with that, because at least, when I was in school, they kind of make it like, oh, if you have a rat info, they're great, but it's not really needed. But like you said, it's great for the conj. But like I said, you will pick up subtle signs because one of our slit lamps, literally, you just pull it in and out, and I'll even like take pictures of this.
Yeah.
Things you would not see otherwise just light up.
And I'm lazy. I don't want to have to look real hard. This makes it easy. So, years ago, I would diagnose somebody with probably H16223 or H04123, dry eye or K-Sicca. But now, because we have targeted therapies, I am much more intentional about looking at how I diagnose and making sure I use the proper diagnosis for ocular rosacea, for Demodex blepharitis, for K-Sicca, all of those components. You have to have a lid and lash strategy. Have the patient look down. It's super simple, but this was a game changer when I started having patients do this every single time, because you see a wealth of things happening there. And this is a before and after, lotilaner 0.25%. What just happened? Blew everybody's mind with that.
Yeah. So that's yeah. So there you go. Well, so this is what the patient sees when you tell them to look down. This is their view. Their view is this, and they're waiting. So I would talk to my patient and be like, well, what I'm seeing here is I'm seeing these collarettes on the lids, and they're like, uh-huh. And so yeah, we're just getting this is the switching into patient mode right
and
now.
this is what happens if you don't do that, then you're you're totally in the dark.
Yeah. So with that I think both of us and many people who have done this have been shocked once they've started really looking at basically the lid margin on every single patient, what they end up seeing.
It's much more common. And even the studies show it's about 58% of the people coming into your office have Demodex blepharitis. And now we have an easy way to treat it. BID, lotilaner 0.25% for 6 weeks. So that's an easy way to do that. You know what? I can still talk. Let me just grab my laptop, because we can talk and still keep our flow. You guys don't need images. We can just have a conversation.
We'll paint you a picture.
Yeah, we'll paint it.
So how many of you guys are having all of your patients look down right now? Okay. So my favorite thing when I ever say about the importance for this, how many of you have ever been behind the slit lamp and you're looking at the patient's eyes for a good minute or so, and then they turn around and they say, so doc, what color are my eyes? And you panic because you have no idea what color their eyes are. And you're like, oh, and then I always, because I'm quick, I'm like, what color do you think your eyes are?
Okay.
And it's always the right answer. Trust me, always the right answer. And the reason why I always like to tell that story, it's because one thing I really picked up my residency is there's a difference between looking and seeing. Because you can look at the surface of the eyes, you can look at that lid margin, but you might not see things when you're looking for it. Because I would say before I really started looking for collarettes, I'd be like, oh yeah, I think I'm pretty good at seeing things.
Yeah.
But then I started realizing when I was actually looking for that, I'm like, I took a look, but your brain only cues in on things you're looking for. So that's why I really say take time not just to look, but to see what's there.
I love that. And remember, there's two types. We were just having this conversation in the back. There's two types of Demodex. There's folliculorum, that's longer. It lives in the hair follicle. And then there's brevis that lives actually in the meibomian glands. Shorter. You're not going to see the collarettes on the brevis. So when you're looking, and you'll start to just identify lids and everything that's going on there, to Corey's point. So that would be my challenge for you tomorrow, is go into your clinics and have every patient look down and just document that and really pay attention to that. That is a huge game changer. Just for sake of time, we actually talked about all that. The mechanism of action of TP-03, lotilaner 0.25%, because this is one of the new ones. This came out last August and was available to us. A lot of you are already prescribing this. And when you look at what's actually happening, it's targeting the mite itself, and it inhibits the GABA-gated chloride channel. So basically the mite can't do anything. It can't eat anymore, so it dies because it's messing with the nervous system. So it's highly lipophilic in nature as well. When you look at how they did the clinical studies, the patients weren't allowed to mechanically do anything with the drop or use any kind of lid cleanser, which is important. You're putting a drop in, but you need that to be on the lashes. That just tells you that because it's the highly lipophilic nature of the drop is how that's happening. And these are just some before and afters of my patients, and this was at 4 weeks. This was right at 6 weeks, and that one was at 6 weeks as well. So you'll see changes 2 to 4 weeks, but Do you want to just have the patient stop it? No, because what's the life cycle of a mite? About 18 days. So that's why you got to do the full 6 weeks.
You gotta hit 2 generations of them, because what they basically do is they go from egg to larva to adult. So the first 3 weeks, you're going to wipe out the adults, but the eggs are going to persist. So that's why you got to do that. You basically have to hit them both in the adult stage.
Questions on looking at lids, Lotilaner, that was one of our big ones last year. Okay. Oh, yes, question. Say that again. With ocular rosacea. Here, it's like. Uh-huh. Yes.
Those vessels. So how do you differentiate? Because rosacea and this is Fitzpatrick 1 patient.
So her question is, how do you differentiate between what's really ocular rosacea and somebody that's just a Fitzpatrick skin type 1 that has a lot of, vessels? And it's a really great question and a point to make about IPL too. We'll talk about that. Because when you're looking at lids, any kind of abnormal vessel that, see if I have an image. You can, if you have an abnormal vessel that's, looking like these, anybody that's a skin type 1, they're gonna have probably Demodex blepharitis. I don't know what it is about that skin type that has that.
Well, they've shown there is a genetic predisposition to both Demodex and rosacea. So here's the thing. Ocular rosacea is also one of the most underdiagnosed conditions, specifically because everyone looks to the face and they're independent conditions. Actually, in about up to 90% of cases of patients who have ocular rosacea, facial signs will be subtle. So that's a big thing too. And if you actually look at the guidelines from the Rosacea Society, what they say when it comes to ocular rosacea, these are the criteria you need to have to at least have a suspect for ocular rosacea. The eyes are dry, gritty, burn. So how many patients of ours are then ocular rosacea suspects? So basically, to your point here, it's not necessarily straightforward. The more you see it, it's kind of like once you see it once, you start to kind of pick up the little differences. But if I see it, I'll tell a patient, you do have these signs of this. Sometimes it can be normal vascularization. But if you happen to notice if you have spicy food or a glass of wine and it gets worse, because the key of these abnormal vessels is they have environmental triggers. So that's kind of it's a 1-2 punch. Do you have the vessels and do you have that environmental exacerbation? For me, that's kind of what puts me over to be like, yeah, you're probably with rosacea.
Love that. Yes. Uh-huh. Okay, perfect. Her question is what was the first, wait, give me the first question again. Yes,
Cool.
thank you. Okay, so the question is, what do we do for ocular rosacea patients? Do we do heat and therapy to the lids in a hot compress, or do we do cool? So in ocular rosacea, I do not use heat because it likes heat, right? All you're gonna do is make those vessels bigger. So I no longer use heat with a hot compress. And then, okay, tell me your second question again. Yes, to make them.
They're underutilized. I was been telling people now we are so in the mode of warm hot compresses, but so many of these are inflammatory, and that's the exact opposite of what you want. So I've actually been utilizing cool compresses more and more. So I mean, because some of this you have to remember is artifact from back when we were first starting to understand ocular surface disease, and we were like, MGD was the major discovery, which it was at the time. So we're like, let's melt the myelin, let's do all of that. But it's evolved so much now more. We know that this is very multifactorial. So yeah, warm compresses have a place, but I really believe we're underutilizing cold compresses.
There's a question online. Why don't they make an ointment for lotilaner to apply on the eyelids instead of instilling the drop on the eye? You'd think that the drop would be less effective eradicating Demodex since it's not on the ocular surface.
So great question. And here's what I do. So in the clinical trial, we talked about the fact that the patients couldn't touch their lids, but I have patients when they put the drop in, because it's a water-based drop, there's going to be extra, right? Whatever's left over, I have them rub into the base of their lashes.
So actually, and then the other part of this is where I get to be a nerd, and I love being a nerd. So the drop is lipophilic. So what else is lipid-based? A lot of our epithelium. So the reason why this was actually part of the R&D for this, when they looked at this, everyone thinks, oh yeah, let's rub it on there. But because it's lipophilic, it actually penetrates into the meibomian glands and into the lash follicles, because those, again, they're lipid-based structures. So it actually gets in there. So it was actually really a great thing that they found, is that you don't necessarily need the ointment because it's going to have that penetration. So it actually comes down to the actual structure and the nature of lotilaner. So yeah, I mean, because logically, most of us would think ointment on the lids, things like that. But that's the reason why, because it's going to penetrate to those structures even in a drop form. And guess what? Drops are a lot easier to use than an ointment.
Especially because they needed it twice a day.
Exactly.
Right?
Yeah.
Nobody's going to put an ointment on in the morning because they're going to be blurry for throughout the day. You had a second question.
Yep.
Tear breakup time. So the question is, how long do you wait to assess tear breakup time once you put fluorescein in? So I have the patient blink. So I put it in and then I have them blink 5 times and then I assess tear breakup time. What are your thoughts on that?
So for me, I normally look twice. I look right after I put stain in to get my first evaluation, and then I basically kind of put it in, take stock of it, and then I do my kind of ocular surface eval, and then I double check afterwards just to kind of get an idea, because you put it in, it can change the meniscus a little bit for that. But I normally take 2 measurements. I'm kind of a 2 measure twice, cut once guy.
And that's a tear breakup time, but to actually assess the cornea, I want to wait at least a minute and a half.
Yes, 100%, because there's a lot of conditions that won't show up until you have glorious late stain, which is one of my favorite terms that is not actually a very familiar thing. And I know that John will later talk a bit about late stain and the importance of looking at that and what that can mean.
Yeah. Okay. The second one that we talked about was evaporation. And we know that, meibomian gland dysfunction is a big contributor to this. And we've already talked about that tear supply demand and the fact that things are evaporating at a high rate of speed based on what our patients are doing. And again, we've got the newest and the only that targets evaporative dry eye with perfluorohexyloctane. We already did my favorite slide, so I'm not going to run us back through this because we did this morning and you guys were all here for that. So the third thing that came out last year was a new cyclosporin, which is 0.1%. So we have 0.05, we have 0.09, and now we have 0.1. And it has a different carrier molecule. And I think this is really important because these are sister semi-fluorinated alkanes when you look at molecules. And so sometimes I think people get a little confused here.
Yes.
So should we talk about that?
We should. So first of all, because this is using another semi-fluorinated alkane, and people have obviously, you think of MIBO because that's the first one we've heard of for this. So here's the other thing I want. So some people okay, so does it really matter if they're different molecular structures? So some other common compounds that are in the same family? Propane, butane. So are you going to put those in your eyes? Absolutely not. So in chemistry, a single carbon can fundamentally change how a molecule acts. So it's just good to know that, yes, even though they're the same family, they are going to have different characteristics.
Right. And when you look at, so it's perfluorohexyloctane, that's what we have in MIBO, the evaporation. This is perfluorobutylpentane.
Yes.
So it has a different chemical structure and it has different properties. It's a really good carrier molecule, which is what you would want in a therapeutic that is carrying a therapeutic medication to the ocular tissues. You don't want something to bob along on the front surface of the eye that you need to actually penetrate. So they work very differently, even though they're both semi-fluorinated alkanes. So I just think that's a really important piece to this. So this was available around January?
Yeah.
Interventional dry eye is certainly something that we are talking about that you may not have heard this term. You probably heard interventional glaucoma and talking about moving from therapeutic drops to MIGS procedures, more procedural based, because long-term effects of what's happening on the ocular surface, as well as compliance issues, all those things happen. So the same thing applies. And so we have interventional dry eye methodologies. This was a study that came out last year, was first published at our academy meeting, looking at interventional dry eye. So they compared tear care directly to Restasis, which was the gold standard at the time, and looking at this over 6 months, and it actually was found to be superior to a therapeutic drop. So just things to consider looking at all of this data on how we do this differently. And so that interventional, and this is just all of that piece, so you guys don't have to go look it up. there's a paradigm shift there in looking into what's happening with our patients with interventional dry eye, because we have more ways to do that. IPL would be considered an interventional dry eye. Corey's going to talk about that later on with you guys today. This was another pivotal trial looking at what's happening when you switch within a class, because now we have more than one cyclosporin. And when you look at glaucoma medications, this is what I do. If I have somebody on a prostaglandin and I don't have targeted IOP therapy, I switch within the class first. I either do a branded medication or just switch to see, can I keep them on just one drop? And we can apply that same methodology. And now we have a study that looks at that these patients were on average, which is crazy, 38 months on Restasis, and they were switched to 0.09%. And that was found to be superior. So switch within the class, just like there's so many like things to do with glaucoma as well as
I
this.
love that. And it's because so often people ask questions are like, how do I do dry eye? And like, that's why I say I always come back to glaucoma, because they're both chronic conditions that we have to actively manage. And the principles are the same realistically. Yeah. And the other thing for that, this is going to become more of a common thought process, because we are now in an area where we have different mechanisms of action for our prescription medications, because we went from the point where we only had immunomodulators, which were primarily targeting inflammation, to now we have neurostimulatory agents. We have tear film stabilizers, much the same way we're going to be having different mechanisms for glaucoma. So if you want a nice framework to think about that, you already have it. So take the same approach that you take to glaucoma management and just shift it over the dry eye.
Perfect timing. So let's end on this one. This is a piece of TFOS DUES 2, just looking at like the management therapies. And it's interesting, like IPL is step 2, but I like having this as a framework, but it doesn't mean that I start every patient at step 1 and I go through all those things before I get to step 3. Sometimes they enter at like step 3, step 4. We're doing an amniotic membrane and drops, and we wind up doing IPL. There's lots of things in here.
Yeah, you meet your patient where they're at, because these guidelines are just that, they're guidelines. And I've never been a big fan of honestly saying like you have to go through this exact algorithm. Yeah. Because for instance, IPL, I will utilize that in a lot of early patients, because again, I want to treat them at their earliest point. The only fault I find in a lot of these stepwise approaches is that they're basically meant to like, well, once the patient gets this severe, then you kick this one in. They're not really trying to prevent, they're more at just giving you this idea. So good to look at to get a general idea of maybe kind of like where the oomph is for a treatment, but not something you have to be beholden to at all.
And I like having a framework inside my practice, because we have more than one doctor that works in our clinic. So I use these to build my protocols. That way, when the patient comes in and they see me, they get the same protocol as my associate doc. And our personalities are different and they might have a different experience in that way, but what we're actually doing with the patient is exactly the same. And so those protocols, it's nice to have a framework that then you can build on that.
Good point. If you work with an associate in your dry eye clinic, like we have one as well who I work with, and we talk about it all the time. Same thing when I came in and started working with Dr. Epstein. You want to make sure you're kind of in tandem with that. So I would agree entirely with that.